Well, good afternoon, everybody. How is everyone? You know, it's really great. We've had people who join in by teleconference, but we also have our friends from some of our mainland clinics up at Victory Lake Specialty Center, so they're all back there on the screen. I hear you can be seen but not heard. At any rate, thank you all for coming at both places, and for those of you listening in, I appreciate you being here. I'm Donna Sollenberger. I'm the EVP and CEO of the health system. I've been here now, 2.5 years. This is my third Mondays in March. I was thinking about it. And I think every single one, I have been the opener for spring break. And I think it's rained. In fact, last year, I think, was the last significant rain we had before the drought. So I don't know what to tell you. I hope past isn't going to be a forecast of the future. But at any rate, last year, you'll recall, we did a theme around taking off. And this year, I thought that our Mondays in March would be about what's happening in flight. It's our in-flight status. Now, I'm not sure when we're going to land, so we may have another in-flight update next year. But at any rate, I was thinking back to when Dr. Callender had been interviewing me for this job. And one of the things that he tried to do was prepare me a little bit for what we might see, what I might see. And one was he threw me some curveballs to see how I would do. And eventually, I came to learn that was just an everyday occurrence. We get curveballs all the time, right? Everybody laughs, so you know what I'm talking about. The other thing that he gave me was the perfect watch for UTMB. And I use that watch a lot. In fact, see, I've tried to stop it, and it won't stop, so I'm in trouble. But at any rate, I thought we would go through some of the things that we've accomplished, and then I'd talk just briefly about some of the challenges ahead. So one of the things we've worked on is patient satisfaction, and I kind of like this little cartoon. Doctor advised me to slow down. Is that why I had to wait 3 hours to see him? Now, we've made a lot of progress on this, and there have been lots of areas, not just wait times, that we've had a lot of work to do. Some of it, in fact, much of it has to do with how do we communicate with our patients? How accessible are we to our patients? I just read a comment from someone, one of our patients who had an appointment and had some questions afterwards, and she was writing to say she was having some trouble getting some answers. And what we'll see is a lot of the communication issues, and so how well do we coordinate? But I think overall we're doing pretty well. Now, we have been in Press Ganey, I think last year we talked about mean scores and percentiles, and this year we moved to percent very good. And the reason that we did that is we really wanted to focus on, we know that in order to make significant improvement, we have to move the 4s, which are good, to the 5s, which are very good. So we wanted to set a target for ourselves and then see how we performed. On the inpatient side, we still have a little bit of work to do, although we've had some challenges in the past, actually, month. And it's, I suppose, a good challenge, but it does affect our staff and our patients, and that is we have literally been at capacity. We have had trouble getting everybody in a timely way, and although everybody's worked really hard to accommodate, that affects our patients who perceive, even though they're admitted, they're waiting in rooms in the emergency room, and so they perceive that they are waiting, and that affects our scores. But there are other ways that we can improve on our inpatient, but we've made some good progress. On our ambulatory clinics, we're doing well. We're exceeding our target in the last couple of months. And on our emergency department, they've done actually well, although you'll see when we have our capacity challenges like we did in November, And we did some in August. You can see what happens. Instead of meeting our goal of about 70% of people thinking we're good or very good, we dropped down into basically the 60s. So I think there's a lot of good progress that's been made, and kudos to everyone who's worked on this. Now, we also have been measuring patient satisfaction for HCAHPS, which is Hospital Consumer Assessment of Health Providers and Systems. And there are 8 areas that they ask patients to rank us on. And notice when I said communication, notice how much 3 of the 8 questions focus on communication to the patient. And then others have to do with responsiveness of hospital staff, pain control. 6, cleanliness and quietness of the hospital environment. You know, all of these, what made me think, because I see people here from the health system and from academic affairs and from business and finance, all of these really cross so many areas. It really requires everybody working together in order to have good HCAHPS performance. So how are we doing for HCAHPS? Well, we've looked at some of our patient satisfaction in terms of our very good, but if you look at how we're doing on our other goals, communication with nurses, if you look at the benchmark, we actually can make some progress, but we are at the midpoint. If you look at our communication with physicians, we've still got a little more progress to make there, both for the benchmark and for the midpoint. On communication about medicines, we're actually doing pretty well, and I think that that's just a considerable effort on everybody's part in order to make that happen. On discharge, we've made some nice progress that I'll talk to you about, and we really are exceeding the midpoint and just almost at benchmark. And on pain management, again, we're a little bit above the midpoint, but have a little bit more work to do on the benchmark. So overall, I would say we're doing pretty well. So why are we going to be focused on this? Well, because we're going to get reimbursement that is contingent on how do we do in these areas. So one of the things that we did, and I'm wearing my button, and there's actually a table out front to talk about our Satisfied initiative that actually started as an idea in the clinics, but we have expanded it to the whole health system. And we also found out that we could take this name and we could basically trademark it so no one else could steal it from us. And so we started our Satisfied initiative, and that was really to create awareness among our staff and among our patients about why 5s were so important to us. We want every patient to feel that they've gotten the highest level of care that they could possibly get when they interact with us, and we want it to happen to every patient every time, no matter where they go. And it's going to help also encourage patients to tell us when they think that there's something else that we could be doing better, and to try to rescue, if we aren't doing well at that moment, try to rescue it then as opposed to a month or so later when they finally send us a satisfaction survey. So we have trained all of our ambulatory ops folks, and we have also incorporated this idea of Satisfied into the new employee orientation. We also have done a lot of work on clinical effectiveness, quality, and safety, and I really like this quote by Jan Carlzone, and it was, quality doesn't mean we have to be 100% better in any one thing. It really means we have to strive to be 1% better in 100 things. And when we look at all of the work that we need to do across the quality spectrum, I was looking at all the metrics this weekend as I was getting ready for a different presentation, and looking at all the metrics that we have to use to measure our performance by. And it's just getting larger and larger and larger. There are going to be about 50 new ones added this year. At one point I went to a presentation where I was told over a period of time that the federal government had intended to really try to measure about 500 things, and when someone commented that it was going to be, how in the world could we do all of that? You know, we needed to focus and get down to really meaningful measures. The person said, well, we're just going to collect it and throw things out there and see what sticks. Well, that creates a lot of work for us if, in fact, these aren't going to be meaningful metrics. And so one of the things that we try to do through the different professional associations that I know our health system team belongs to is try to advocate both at the state and federal level more for consistency in how we report, and also for trying to focus the measures that really will be meaningful for the outcome of our patients. The other thing that I liked was this comment on Think Ahead in Healthcare blog, and they had the slogan, no outcome, no income. And you'll remember for years we've said no margin, no mission, but really healthcare is moving to being outcome-based, and we're going to have more and more of our compensation for the care we deliver put at risk because of this. So we want to make sure that our outcomes are really good if indeed we want to continue to have margin. And if they're really good, there may be some incentive for us for some extra money for doing things very, very well. So one of the things that is important is this whole idea of value-based purchasing. And I told you that HCAHPS, the patient satisfaction, is a portion of that. But then so are the National Hospital Quality Measures. And in fact, by 2014, just based on our Medicare volume today, up to $2 million could be at risk for our performance. So if we don't perform really well at all, we would lose the whole $2 million. If we perform well, we can achieve that $2 million, and we're still hoping that if we achieve very well, that we could achieve a little more, although I think that's still up in the air and probably wishful thinking on my part. But one of the things we've also learned is that the insurance companies are starting to say, you know, if Medicare is going this way, so are we. And so United said that, Blue Cross Blue Shield, I know in New Jersey said that. So we can expect that this new payment system of you must get certain outcomes in order to achieve the full income is really going to affect all of us. And so we really have to focus on our mortality rates, our readmission rates, our healthcare acquired conditions, our patient safety indicators. And so this is really a focus that we're working on. And I know Dr. Mark Kirschbaum and his team are working to put together some dashboards that we can use, kind of tell easily how are we doing, and how are we doing on our unit, or how are we doing in our clinic, because just this sort of broad metric, it's hard to understand, you know, how are we doing individually in our own units. So the first year, which is FY13, the baseline period is July 1st, 2009 through March 31st, 2010. And the performance is going to be based on July 1, 2011 through March 31st, 2012. We have, I don't know, what is today, the 13th, 12th. So we have, you know, about 19 more days to improve our performance dramatically. I'm being silly, but this is, we have to really continue to perform well in order to earn these funds back. And each % reduction that we're going to see just in Medicare alone may be up to $250,000. Now, based on what we can expect, because you'll say, well, you said 2 million, each year the risk gets greater, and in fact, after the 2014 performance year, the Health and Human Services Secretary can add 2% of withhold each year at his or her own discretion. So this is a big deal. But of the 260,000 approximately we would have at risk in this year, right now, based on our performance, we would earn back 200,000. So we're still, you know, 60,000 on the table, and some people may say, well, in a $1.2 billion, that's a rounding error. But you know, it's also a nurse, or some environmental services workers, or pharmacist, you know. So these really do make a big difference because we want to be able to earn these funds back so we can continue to have the really great folks we need to continue to do well. We've also been working on, and I'm just going to touch on this briefly, but Bill Elger at his Mondays in March next Monday, and I hope you all can come to that, we'll be touching on it in more detail, but we've embarked on a UTMB Connect project. How many of you have heard of this? Good, most people have. But this is a really important project to us because it's really taking our information systems and making them contemporary for many of the things that will be coming our way and trying to get us completely automated and integrated. So we have established, first of all, this website called UTMB Connect that will have important announcements and information online about the many things we're doing to systems like scheduling, registration, billing for the hospital side, billing for the physician side, trying to now start linking our, what we call those 4 systems revenue cycle with our clinical information, the Epic that we've been using in our clinics and in our outpatient units, and trying to get more integration. We also are preparing us for what's called ICD-10, and this is how we identify the diagnoses for the patient. It's a number we use, and everybody will use the same number if you have asthma. Well, now we're going to have this explosion of diagnoses from which we can choose, which are a lot more specific. And for us, as an organization that does a lot of research and that we want to monitor and look at populations of patients, this is really a good thing because we can be a lot more specific and discrete in the information that we have available for research. It's also a huge hurdle because we have to have this in place by October of 2014 or we can't bill. Can't bill. Well, one of the things that apparently a lot of people are struggling, I think we're doing well, but it's a real effort, is this deadline. And so the Health and Human Services Secretary, Sebelius, said that she will look at this deadline to see if it's going to be hard and fast, and there's a lot of speculation that it might change. But I think we just need to keep going. We've got a good structure, we've got good people in place, and we need to continue to move forward with this project. We've also been doing a number of things to give our staff tools for being able to focus on quality and effectiveness. So there's the Clinical Safety and Effectiveness course that focuses on safety and outcomes. This is training for how do you improve clinical processes and the outcomes that you get through those. So one project, for example, might be how do we reduce readmissions among a population of Medicare patients with chronic obstructive pulmonary disease, COPD. This trains clinical folks primarily in how to look at these and do these improvement projects. This was generously funded through UT System for quite a few years, and our folks used to go to MD Anderson for the training. In January, we started our own course here, which really cuts down on the travel time that people have to spend so that more people could dedicate the time to participate in this training. We've also done LifeWing's Crew Resource Management, which focuses on safety. Started out in the operating room, and what it basically does, it trains everyone to say, if you see something that you don't think is the way it should be going, you can basically call a timeout for everybody to review what's happening and to make a decision before moving forward. And that may sound, well, sure, wouldn't anybody do that? But not everybody feels empowered to do that, and not everyone always receives that request or that concern as generously as we might like. And so there was a lot of work that went into training literally hundreds of people in this, and we are, as the new residents come in, as we have new faculty, they go through this training too, and we're extending it to some of our procedural areas where it really makes a lot of sense to do that. We've also been doing the Plan, Do, Study, Act approach to a lot of our performance improvement work, and many people in the departments use that, and that helps to address, among other things, patient satisfaction and quality. This year, we started training for people on lean resource management, and this was an approach to trying to have good quality at lower costs that had initially started in the automotive industry by Toyota. It was adopted in healthcare, started being adopted several years ago, and we decided this was something that would be helpful. So in the health system, we've trained a couple of dozen people who've been working on lean projects, and there's a table out front that shows some of those. And then business and finance also did some training for their staff that Bill Elger will tell you about next week, I'm sure. But we've really tried to focus a lot of energy around how can we do something better at lesser cost but not compromise the quality. And there are many learnings that we're finding from this. We've also been trying to emphasize culture of trust, and I'm going to talk about that a little later. And then we've had a number of people that we have trained in how to disclose and apologize to patients if we have made a mistake. And that's, again, an initiative that's very much prompted by UT system, but we know from a risk management perspective that if we make a mistake, whether it harmed the patient or not, we need to disclose it and we need to apologize for it. You know, think how you feel if something, let's say something's amiss with your car. You take it in and it's still, you know, something else is amiss. That's happened to me. I take it in, I think they do it on purpose, and then, you know, you get it and it doesn't work, something else doesn't work. But if you take it back and they try and say, oh no, everything's fine, and you know it's not, that makes you not trust them, correct? But if you take it back and they acknowledge, yes, there is a problem, they'll be happy to take care of it, and they acknowledge it wasn't there when they got it the first time, you are willing to give them a lot of goodwill because everybody knows that people do make mistakes. And so we want to apologize, we want to disclose them, and we want to apologize for those. We've also been busy getting regulatory accreditation and certifications. I'm not going through all of these, but this is a tremendous amount of work that everybody has done. We did last Friday finish the the National Accreditation Program for Breast Centers and got rave reviews for the multidisciplinary care that we do in our breast center. So kudos to Dr. Silva and the entire breast center team. Some of you hopefully are up there in Victory Lakes. And to Barb Pettit for her leadership in making that all happen. But tons of work has been done to get us VAD, ventricular assist device certification, to get us burn certification this year, to extend our certification at Victory Lakes, on and on. And the big one, notice it's bold, the Joint Commission. Oh my gosh, you know, I'm going to measure my life in Joint Commission surveys. In fact, the other day I thought, I wonder how many more of these I'll have till I retire. But at any rate, every 3 years the Joint Commission comes through, and it's good for us, you know, as much as it's kind of like eating peas, you know, it's good for you, or carrots. It's good for you to do, but between now and January of 2013, we can expect the Joint Commission to be here. So you're going to hear a lot of readiness work that will start, and more about that, more and more emphasis until the week they show up, and then the world stops while we, yeah, everybody's nodding, yes. The world stops while we work with the surveyors. But we have a readiness group that meets on a regular basis, and hopefully we are ready. We did our periodic performance review. It's an annual assessment, our own assessment of how we're doing against the standards, and we found some things that we need to work on. But overall, you know, I really appreciate everybody's work to continue to keep us in this constant state of readiness. I want to talk a little bit about employee growth and management. And I always like this story about LBJ going to Cape Canaveral, and he asked an environmental services worker, "What's your job?" And his answer was, "I'm helping to put a man on the moon." I hope that everybody who works at UTMB feels truly connected to the mission. Some of you work more in research, some of you work more in education, some of us work more in patient care, others of us work supporting all of those missions. But suffice it to say that every single person has a profound impact on how well we do. I remember one place one of my proudest moments is when I talked to one of our environmental services workers about why he liked his job there, and he said because he helped to contribute to patients getting better. And I asked him how that was, and he said, by making sure the rooms are turned over quickly, that they're cleaned well so the patient doesn't get infection. And you know, I really encourage every single person who works here to think about, how am I connected to the mission or missions that I support? Because you are, and you make a tremendous difference on whether or not that we are successful. David Marshall just had to duck out for something, but we have many people from nursing here who have been working very hard on regaining our magnet status. And so we submitted our application on time on February 13th. We found that we met the level of excellence for magnet in 79 out of 88 sources of evidence. They have asked us for additional information, which we are submitting by this week. I'm sure Barb Bonificio is running around collecting information as we speak. But the next step will be, once we've submitted that, David Marshall will be notified that documentation scores are in the range of excellence for magnet certification based on the data that we submitted. And then Magnet will schedule a visit to verify that what we've said we do, we're actually doing. And once that visit's complete, then we would be able to re-achieve our magnet designation. That's a really important piece for us. And some people say, well, it's just nursing. But it's not. Being a magnet center, really, the idea was to attract, top-notch nurses, and that you have top-notch nursing. But it also attracts many other types of professionals who know that if you have this designation, that you're the kind of place where they want to work. We also have adopted new uniforms, and that's not been without its controversy. In the outpatient center, which is the picture on the left, those are the uniforms that the LVNs, the MAs and techs, and the RNs will be wearing. On the inpatient units, the RN on the left and the PCT on the right. These, let me point out what I like about it. And would these be the colors I would have chosen? I don't know. Didn't have to, that wasn't my decision in the end. This was done by our nursing councils, and there was a vote, and I really appreciate the fact that it's our employees who said, look, we want to standardize, we want people to be able to recognize quickly based on what I'm wearing, what role I play. And so I really appreciate all the nurses who did participate in this and support personnel who participated in this process. I told you about the lean teams. I thought this was this is what we're really trying to do, is get more efficient. And we did have, as I mentioned earlier, 9 projects that we completed. And we have found that overall the thing they had in common was they all reduced waste, they all increased value for our customer, they all reduced costs, and they all improved employee satisfaction. And we're projecting those projects will save a little over $100,000. And again, just think if every area worked on something like this, how much more we could improve our systems and also our outcome and save money. So I think this is a great approach that you're going to be learning more about. And you may be asked to join a lean team or be trained in lean as well. And we hope that you will. And we have 16 additional projects currently underway. We've also had great success this year in care management. I mentioned this last year that Jennifer Zirkle was helping to lead a whole transformation of our care management. She was recently appointed the permanent director of care management, and we had exciting news when Dr. Quach and some folks interviewed and selected 2 physicians to help work with our care managers and interface on some of the complicated and complex issues we have around patient care, particularly right now focused on the inpatient side, but I think there's work that we can do also on the outpatient side in the future. So Dr. Jernilov and Dr. Marks have been named in those positions. We've been evaluating some software to see if we can get better workflows. We focused a lot on the length of stay of patients who are here 10 days or more. And we've really had some interesting findings. Many of the patients are here because they need another level of care or they need certain types of support that they don't have when they leave our hospital. And so we can't discharge them until we feel comfortable that there's a plan of care that can be executed on their behalf once they do leave. But with some really great work on our care management team and our physicians and everybody else who touches our patients, we have had a reduction to date in our length of stay by 0.3 days, and that's an annual savings of $3.3 million. So kudos to everybody who has worked very hard on this. And on the long stay patients, we've reduced them from 21% of our stays to 12%. So again, a lot of great work has been done on getting the patient discharged to the appropriate level of care in a more efficient manner. We also rolled out MyChart, and now more than 10,000 UTMB patients are enrolled, and they can do a variety of things from viewing their lab results to asking for refills for their medications, just requesting an appointment be scheduled, look at their after-visit summary. I go to the doctor, and sometimes by the time they're done, you're thinking, I don't know if I remember everything they said. Well, now you can go look because the summary's there, so you can see what it was and kind of revisit that so you can do a better job of your care once you leave. We also, this year on February 9th, closed Austin Women's Hospital, and it really was bittersweet because that was a fabulous service to that community. However, things had changed over time. When we first started doing it, they were going to be our faculty and our residents, and over time, they became UT Southwestern's faculty and residents, so we were simply managing. So we worked with Central Health, which is the county health system in Austin, and we basically effected a smooth transition as of February 9th. And we had a really kind of bittersweet luncheon for all the people who had worked there who had made that contribution. But we owe them a lot for the 8 years that they spent doing a tremendous job up at Austin Women's Hospital. Correctional managed care, I want to touch on this because it's been, we've taken a lot of time on this year, as we should. But it's been a very unsettling period. But we do, through all of this, we are very, very appreciative of the physicians and the staff who work in correctional managed care because they have maintained a quality of care and access despite some very unsettling times and a lot of change. We changed the entire outpatient model of care and had considerable savings from that and still maintain quality and access. We've been negotiating our contract, and we have completed the FY12 negotiation where we know UTMB will be reimbursed its costs, and we have FY13 under active negotiation, both with TDCJ and with legislators and legislative staff to try to come up with some final contract for that year that would basically assure that we weren't going to lose money on caring for this important population of patients. But in case that didn't happen, we have developed a transition plan and reviewed it with TDCJ. For those who are listening in or who might view this later from TDCJ, I want to tell you one thing. These patients aren't going anywhere. I mean, those patients are still going to need care. They're going to still need your care. And so we will work, whether we're the employer or it transitions elsewhere, we will work very hard. You're doing a tremendous job and an important job. And, you know, I really am very confident. We've gotten a lot farther than I think anyone else thought we would get at this point. And I think that we still have every reason to be optimistic that we will be able to continue this care through FY13, but we've got some work to do to make sure that we're not financially at risk for those for that care. Last year, had we not gotten some supplemental funds, we would have lost over $40 million. We can't afford to do that, as you well know, but we can, if we're reimbursed our costs, afford to do what is, on a per offender per day, one of the lowest costs in the country with the highest quality outcomes. So we're doing a great job at a great value. We hope that our colleagues in Austin and at TDCJ will recognize that. So thank you to everybody who's been patient in CMC and worked with us on this. We've also been working on market position, and I thought this was cute because we've talked a lot about all the places we are off the island now. You know, we have clinics here, 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 and here. And that's really what a lot of effort has gone into. We also, on our market position, I put this first. We got the new Jenny Seeley Hospital approved, and what a great moment for UTMB last August when the Board of Regents approved it. And what I loved was, you know, it was presented. Dr. Callender did a great job of presenting it, and then it was open for discussion. There was never a discussion about whether we needed this, whether we could accomplish this, but the comment from the board members, the Board of Regent members, were, you have done a heroic job in Galveston, one we never thought was possible. And then they voted unanimously to let us move forward. This is that was a great day for UTMB. And now, if you've looked over where the old Jenny Seeley was, it's nothing but, as Jake Wolf said on the video 18 times, rubble. So we're going to have a fabulous new hospital with all these wonderful things. We also opened the multi-specialty center and Stark Diabetes Clinic up at Victory Lakes, and many of our medical specialties were able to consolidate into that location. And you know what? Our employees love it, but more importantly, our patients love that. They love going there. It's wonderful, beautiful, supportive space, and we appreciate everybody who worked hard to make that happen. In the process, we were able to also discontinue and save money on some leases where we had multiple clinics scattered about. They're now consolidated into this one beautiful, wonderful location. We also finished renovation of units. The blocker burn unit is about halfway complete. We finished 7C and 8C. They were C and D, but we went from 32 to 16 rooms, so we said we'll just call them C. So 7C and 8C. We also finished labor and delivery, which is a fabulous, wonderful, beautiful new space. And we're going to continue to expand some on the burn unit. The second half is under construction, and some infrastructure projects that will create more reliability and modernize our infrastructure for us in the clinical care area. And we appreciate all of our colleagues from FOAM that have worked on this, sometimes with many ups and a few downs. But we got through it, and we've got great spaces for our patients. We will have our primary care pavilion opening soon on the island. People sometimes say, well, what are you doing on the island? Well, we're going to open the primary care pavilion, and a number of The primary care physicians and their practices will move there, plus we'll be moving orthopedics and have outpatient rehab there, or so that we, outpatient physical therapy, so that we can begin to have a much more accessible place for patients who need primary care and for people who are on crutches. You know, we're going to not make them go through the labyrinth of the hospital, hoping that at some point they'll come across a sign that says physical therapy. We're going to make it easier for them to get here. And then the other exciting part is at Victory Lake Specialty Center, we're going to be opening tomotherapy, which is a form of radiation therapy, in May, and in July we're going to move the Dickinson Cancer Center into Victory Lakes and be doing infusion and see our patients there, so a lot of exciting things. And then we're going to, when the primary care moves out, restack our specialty care within UHC. This is proposed, still needs a lot of work, but what we're trying to do is create common adjacencies where people have a lot in common with the folks who are practicing next to them. And then the hospital concourse project is starting. So we'll modernize the major path from the front of John Seeley Hospital all the way through to UHC. And this is just an artist's conceptual rendering of what concourse might look like, although I think that was a connection between Jenny Seeley and Waverly. But we're still going to have a beautiful concourse for people to walk through. We've spent a lot of time on the Medicaid 1115 waiver. What's that? Well, the state of Texas received a waiver from the federal government to be able to organize how it delivers care to its Medicaid patients differently. And it's going to focus on moving about 1 million people who are on Medicaid now into Medicaid managed care, where there are already about 2 million enrollees. So it's going to push all of the Medicaid population into Medicaid managed care. And then it's going to start reimbursing hospitals differently on 2 components. One, they're on compensated care, and the second on innovation projects in care delivery that we could demonstrate and then that could be replicated across our entire area or even Texas. And so we have been working on this. We've proposed to anchor a 27-county area. Why 27 counties? Because we already have tons of clinics and outreach and work that goes on in those counties, and we want to try to coordinate all of that and work with our partners in the counties to do so. Financial success, I found a picture of David Connaughton at one of his staff meetings. I know, there he is. He's like, could you ever just do a Mondays in March without me in it? But no, I can't. So we're going to build on looking at some of our admissions. So if we look at where we are in terms of FY12, a little behind our budget, if we look at UTMB without TDCJ and Austin Women's Hospital, and we are ahead of where we were last year, though. If we look at putting on TDCJ, intentionally we have reduced those admissions through better management, and so we are basically a little bit ahead of where we thought we would be in the budget, but below where we were last year. And then when we put Austin Women's Hospital on it, so when you see the bar, you see that we have we are behind in our overall admissions from budget and a little behind from last year, due in large part to Austin Women's Hospital and also TDCJ. If we look at our clinic visits, these are our RMCHP, Regional Maternal Child Health Clinic. And again, we're running behind budget and behind in our, from last year. Our island clinics, we projected that we would be at about 60,000 visits, and it looks like they're on track for 67,000. So we've actually picked up some business that's coming here. And then when we look at where we are with our mainline clinics, far ahead of where we were last year and almost at budget, and Diana Browning and Dr. Rex McCollum assure me that this is just, we're going to be at the budget by the end of the year because we've had different clinics opening and haven't had a full year of experience yet. And then when we add Victory Lakes Specialty Center, they're doing very well too, ahead of last year and ahead of budget. So clinic visits are a little bit behind, but we think we'll catch up on those. So overall, this is the eye test. Dr. Godley appreciates that. If you can't read it, go over to University Street and make an appointment, have your eyes checked. But if you look at where we are in terms of our contribution margin, where we want to look at is to your right on year to date. The health system is doing a little, the hospital and clinics all funds is doing okay. We need to really try to, we're about $6 million off. We need to do a little bit of work. But we also think that there's a lot of good management, and we also think that as we always come on stronger toward the end of the fiscal year than we do in the beginning. So I think overall, I think we're in a good place, and I project that we will end the year on budget. So I want to kind of end with looking ahead, thinking about are you an engaged employee committed to the work that we have to do? And the difference between involvement and commitment is like a ham and eggs breakfast. The chicken was involved and the pig was committed. So I want you all to be committed to the work that we're going to do. I don't want to say be a pig, but I want you to be committed to the work that we're going to do. So are you committed to all the work we're doing in patient satisfaction, trying to make this the best place for our patients? Every patient, every time, every place gets the best possible care. Are you committed to quality and safety, where you know that everyone has a role in that? We acknowledge systems fail, not people. This is the whole culture of trust you're going to hear a lot about this year. We're all involved in designing systems so that it makes it hard to fail. We feel safe reporting our errors. We feel free to speak up, that no one's going to climb all over us for doing that, and that we believe and foster an environment of trust and accountability. I trust you, and you trust me. You hold me accountable, I hold you accountable. It's through that that we can be successful, but do it in a blame-free environment where we're really focused on improving our processes because we have good people. We want everyone to be able to look any potential patient in the eye and say the care you're going to receive at UTMB Health will be the same as I would want the most cherished of my loved ones to receive. We want to say that to everybody. That's a stretch goal, but isn't that what we all want? We want everybody to come here and be able to know that. Are you committed to helping make UTMB a great place to work? Do you speak well about and support your colleagues? Do you orient and onboard new people, or do you eat them alive? You know, we can't, if we don't, it's hard. New people come in, and it's a lot of time getting them onboarded. But if we don't do that, we're going to get a reputation of not being a place you want to go to because you're not going to be successful. Do you live the values? Are you compassionate? You work with integrity, respect, diversity, lifelong learning. Do you speak well of UTMB when you're out and about, or do you stand in the store line going, oh my gosh, yeah, I work there? But you know, we want to be able to be engaged and supportive, knowing we've got things to work on, we've got a ways to go, but we're working on things that are going to make us better overall. Are you committed to operational efficiency? If you're asked to be on a lean team, do you do it? Do you make suggestions for improving patient safety to your manager or to others that may be able to help? Do you help coordinate care if you're in that role to increase efficiency? Do you use good hand hygiene? Your mother told you, always wash your hands. And that's going to be more and more important. There was in Joint Commission up in Dallas, there was a place that, what will remain nameless, but it was in Dallas. that they almost lost their, well, they got conditional conditions of participation in Medicare because they observed people going in and out of rooms without washing or without gelling their hands or washing their hands. This is very important. We can stop germs. Now, there are little bottles of this for free out on the tables, and we're going to distribute these to every unit, every clinic, every area where people come in contact with patients. Because, you know, I've had people say, oh, I knew I had to wash my hands going in, but I didn't realize I had to wash my hands going out. Both. In and out. And if you don't see people doing it, let's feel free to talk about that in that culture of trust, not because we're trying to make someone feel silly, but because it's the right thing to do for our patients. Are you committed to operational improvement? I'm not going through all these, but we got a lot of stuff going on. But they're all about how do we create a better environment for our patients to receive their care, where that care is coordinated, there's better communication, we can care for them more outside the hospital, not inside the hospital. In these times of rapid change, time is not on our side. I've heard more people say, oh my gosh, everything's going at warp speed. You know, the clock, the UTMB clock we had, but it's important. We've got to do it, just like Mr. Snowman here tells his friend. We've got to be able to do all of this change at really a warp speed. Are you committed to our financial success? Do you help make sure we're capturing the charges we should? If you were involved in variance reporting, you're a manager or a budget leader, do you participate as you're asked? Do you help develop business plans? Do you help if you're asking the 1115 waiver? Are you participating, if appropriate, in the UTMB Connect project? All of these are critical to our future success. And remember, no outcome, no income, and I still on this say no margin, no mission. So we've really got to work on that. But are you committed to assuring our bright future? We have a wonderful future. Look at all the things that we have either completed or are underway that really will position us to be the great place that we are and make us even greater. So the future is unpredictable. It's going to require diligence and planning, and sometimes our best case scenario, our worst case scenario is now our best case scenario. But that's just a fact we're going to have to live with. But change is inevitable. We can't stop it. It's going to come, and it's going to get us unless we're really proactive. But it's going to require real change. We can't just tinker around the edges like, you know, you can, like the Dallas DJ, you can put your boots in the oven, but it don't make them biscuits. We've got to change how we do things, and we have to have real, substantial change. It's going to require courage. Like John Wayne said, courage is being scared to death, but saddling up anyway. And I got to tell you, even as your leader, there are days when I'm kind of scared to death. So if you're feeling like, oh my gosh, we all feel that way. But I have a lot of optimism that we're going to get to the end and be really successful. We are well organized to be successful in this new healthcare paradigm. It's going to require lots of teamwork, just like on a football team or on a basketball team. Sometimes I say, you know, we're sometimes even picking teams and we don't know what game we're playing, but we've still got to pick teams and keep going. But in the midst of all this difficulty lies the opportunity. And Galveston, we have an opportunity. And we will, I think, make good use of our resources, our people, most importantly, and the things that have been given to us to be able to do a better job for our patients, for our research, for our students. This is a tremendous time. So I see my time's about up. So I'm going to see if any of you have any questions, and if you do, would you please step up to the microphone? Okay, I'm going to lose on the question thing now this year, too. Third year in a row. That's okay. I just figure I covered everything so well that it was crystal clear. you all for attending and listening. To those of you who will take the time in the future and will be watching this either remotely or in a break room somewhere, I want to thank you for doing that, and I want to thank you for everything that you do. I'm patient care, so I really appreciate everything you do for our patients and families, and I look forward to giving you a much more optimistic and an even more optimistic report next year. So thank you again.